Thank you for joining us and welcome to the second Kyushu Myanmar Medical Education Seminar. I'm Dr. Tomohiko Moriyama from Kyushu University Hospital, Japan. Before starting this session, we'd like to have an opening remarks from Dr. Professor Zo So. Would you give us some brief talk?
Yes. Thank you very much, Professor Tomohiko Moriyama. First of all, I would like to say thanks, and also I would like to greet you all. Good morning. I think good morning in Myanmar, and good afternoon, konnichiwa in Japan. And as to all the audience from Myanmar and audience from Yangon and audience from Japan. Actually, as you already mentioned, this is the second Kyushu Myanmar Medical Education Seminar. Actually, we participated in the 67th Myanmar Medical Conference, organized this seminar organized by the Kyushu University Hospital and University of Medicine 1 Yangon jointly organized. And actually, we have discussed just now, COVID-19, because of the COVID-19, otherwise we will be face-to-face conference in the Myanmar and then participating in the Myanmar Medical Association Medical Conference. But I think that COVID, there's some opportunities because we are now more connected. I mean, you can participate from all over the world, not only from Myanmar. That's why, Myanmar doctors from the remote area, Myanmar doctors from the other region, and Myanmar doctors from the hard-to-reach area, they can join this meeting. And also, at the same time, we can share and we can have, audience from the Japan and other countries. That's why I think COVID-19, we have some good things and bad things we're having. And I also like to acknowledge and also congratulate, Professor Shuzi Shimasu, because, his futuristic thinking and advanced idea since 2002, telemedicine development in Asia. I think this is a very much ahead of time thinking. Because of that, in COVID crisis pandemic, our telemedicine program is very much, advanced and useful, and then also having connected between the two country and university, Kyushu University and Myanmar University. And actually this program funded by the Project for Global Growth of Medical Technology System and Service through the Human Resource Development in 2020 and National Center for Global Health and Medicine under Ministry of Health, Labor and Welfare Japan, supported by the JTEC. And today, conference, we have two sections. This is the first section. This is first section regarding with the endoscopy. And I would like to thanks to the Professor taking the chair and then also participating and then also organizing in this section. And after that, we have a second section. It will be a surgery section. And then at that time, Professor Chung will be participating as will be chair with the sharing with the Professor Shuzi Shimasu. And I don't want to take that much time. I would like to congratulate and I would like to thank all of you, all the speaker, and then also organizer who organized to come through the endoscopy section in the Myanmar Medical Association conference. Thank you so much. Thank you. I would like to hand it to the Professor Fabian, please.
Yes, the first session will be chaired by Professor Moriyama. So Professor Moriyama, could you please chair the first session?
Okay, thank you. Okay, I'd like to talk about gastric cancer as a first presenter. So please share my slide. Okay, today I'd like to talk about an approach for elimination of gastric cancer deaths. Okay, this is the heat map of gastric cancer incidence. Actually, Japan and also Myanmar is one of the high-risk area for gastric cancer in the world. But its situation is a bit different. In Japan, incidence is very, very high like this, but its mortality is less than 1/3 comparing to its incidence. But in other countries, including Myanmar, its incidence and mortality is almost the same. It means once the patient is diagnosed as having gastric cancer, most of them died of gastric cancer. So what is the key factors of low gastric cancer mortality in Japan? Actually, there are so many new factors like this, such as a cheap health checkup system, free access to healthcare providers, low patient copayment, many endoscopists, various new modalities, but most important factor is early diagnosis. Uh, Actually, the most about 70 to 80% of gastric cancer is diagnosed in early stage in Japan. On the other hand, as you know, H. pylori plays an important carcinogenic role in gastric cancer. Once the H. pylori infected the normal mucosa, chronic gastritis happens. And based on the chronic inflammation, mucosal atrophy is induced and the gastric cancer arises from those kinds of atrophic mucosa. So other way to reduce the gastric cancer mortality is eradication of H. pylori, like this. Okay, this is the report from Japan in 2008. This is in these patients, H. pylori was eradicated after endoscopic resection, and comparing the patient was divided into two groups. One is eradicated group and the other is a non-eradicated group. Comparing to these two groups, gastric cancer incidence decreased to 1/3 by H. pylori eradication. So based on this study, all the people with H. pylori was covered by health insurance system for eradication in Japan. And furthermore, since 2000, the patient with peptic ulcers or some other diseases which related to the H. pylori infection was supported by the health. By those kinds of people are supported by health insurance coverage for eradication. Furthermore, its copayment is very cheap, around $15 US dollars. And furthermore, the prevalence of H. pylori in Japanese is dramatically decreasing due to the rapid improvement of public health. So of course, still the elder people are H. pylori eradication, H. pylori ratio is high, but in teenagers, the H. pylori infected ratio is less than 10%. Even in this situation, gastric cancer incidence is not so decreased actually, comparing to its mortality. So that's why I think to reduce the gastric cancer mortality by H. pylori eradication like this, long time is needed. But the decreasing gastric cancer mortality is emerging. So we should find the gastric cancer in early stage. These are the requirements for early gastric cancer detection by endoscopy: adequate preparation, reduction of blind spots in the stomach, enough examination time for endoscopy, and good endoscopic photos, and of course, knowledge of endoscopic findings of gastric cancer. Just after intubating the scope, we can find the mucus and forms on the gastric mucosa, like left pictures. So first, we should remove mucus and forms using the adequate water or something. And then we also should take care of the blind spots. Actually, there are numerous area of blind spots in the stomach during endoscopy. This area is a high risk for the sometimes we miss the tiny lesion in this area: posterior wall of corpse, lesser curvature of cardia, greater curvature of fornix. So we should take much care to watch this area by endoscopy. And examination time is also very important. This study compares the two groups. One is a group, the examination time is less than 7 minutes, and others are more than 7 minutes. Comparing these two groups, the neoplastic lesion detected is totally different. So we should take more than 7 minutes in one endoscopic examination. And also we should take good photos. What is good photo? No forms, no mucus on the mucosa, no residue, no camera shake, and also adequate air volume is very important. And we should take many photos in adequate position. And if there is a lesion, better to make lesion in the center. Then we can find a subtle change of gastric mucosa like this. Actually, there are 3 early gastric cancer in this photo. All these lesions were treated by endoscopic resection. Also, we should take care, these are the tips for early gastric cancer detection. Usually, early gastric cancer shows flat form, so we should take care of these findings: slight surface changes, color changes, disappearance of vascular networks, changes of light reflection, thickened or irregular fold, and spontaneous bleeding. So daily and continuous education is quite important. Based on these good photos, we can make a discussion or a lecture. We can get advices from experts, and all the photos taken by young trainees were reviewed by our colleagues. And also we can brush up our technique using simulator or something. And now, as Professor Zhou So mentioned, we can learn and share the knowledge through the internet like this. We have many teleconferences with Asian countries. This photo shows an endoscopy session connecting many Asian countries. At that time, the doctor joined from the Myanmar like this and have some discussion and share our knowledge with Asian friends. So if you are interested in, please contact us. Okay, these are my take-home messages. Only H. pylori eradication isn't good enough to reduce gastric cancer mortality. Endoscopic exam is essential to detect early gastric cancer. We can share knowledge and experience for early gastric cancer detection through international teleconferences. Thank you for your attention.
Thank you very much, Professor Moriyama, for your very informative information about H. pylori and gastric cancer. So could you please introduce the second speaker for our session? So could you please introduce the second speaker for presentation?
Okay, all right. Okay, then
Are we going to have a question after all the presentation?
All the three speakers.
Right, okay, good.
I got you. Okay, then I'd like to invite the second speaker. Second speaker is Dr. Takahisa Nagahata. Right, he's an endoscope. Okay, he will talk about the colorectal cancer. So would you start presentation?
Thank you for introducing me. I will talk about how to detect colorectal cancer. This is a heat map of age-adjusted mortality rate of colorectal cancer in the world. This is higher in the Japan, and Myanmar is here. It's slightly lower mortality in the Myanmar. Then this is age-adjusted incidence and mortality of colorectal cancer between Myanmar and Japan. It is similar to gastric cancer. In Myanmar, incidence and mortality is nearly. In Japan, incidence is higher than mortality more than 3 times. Then, similarly, gastric cancer in Japan, incidence of cancer is higher number, but mortality is low, about incidence of cancer. Then importance is first detect of colorectal cancer. In the first background, adenoma can lead to colorectal cancer is known about it. And but 20% of adenomas are missed during colonoscopy one times, and 3 to 8% of patients with colorectal cancer had a colonoscopy within 3 to 5 years ago. Then, increasing adenoma detection rate, its ADR can reduce colorectal cancer deaths. This is what is ADR, adenoma detection rate. It is rate of number of cases having more than one chronic adenoma in number of cases underwent colonoscopy. This is a date of adenoma detection rate is a good quality indicator of colonoscopy. This ADR in this part of ADR is higher than half year to 5 year who detected who was underwent a colonoscopy and detect colorectal cancer is higher than the lower ADR of who went a colonoscopy test. Then it is a relationship of ADR and colorectal cancer. Then lower ADR for 30 or 50% is more low risk of interval colorectal cancer. Then each 1% increase of ADR was associated with a 3% decrease in the risk of colorectal cancer. Second, why a chronic lesion was missed in colonoscopy. It is related to poor skill of endoscopies, anatomic problem like hepatic or splenic fracture and chronic folds, and it is missed problem of missing flat regions, and preparation of colonoscopy is a problem. Then I will speak about anatomical problems and how to detect flat regions. It is new techniques of colonoscopy, cap-assisted colonoscopy, and retroflex technique, and water exchange colonoscopy. Then I will speak about cap-assisted colonoscopy and retroflexion technique. Using a cap like this and into cap-assisted colonoscopy is using like this cap and hold a chronic fold. Then we will easy to detect adenomas, the other polyps like this. Reflection techniques is reflection like this. The behind of the polyps and behind the fold, and reflection technique using we can see the adenomas, and in rectum difficult to see these polyps to usual way, but using reflection techniques we can see these polyps yes. This is efficacy of cap-assisted colonoscopy for adenoma detection. This data using a cap-assisted colonoscopy, and it is we can shorten the insertion time to the cecal fraction, and more detection rate of adenomas in this case. This is a technological advancement in colonoscopy. High definition colonoscopy, wide angle colonoscopy, and side retroscopy, scope, and full spectrum endoscopy, and more. We'll speak about high definition endoscopy and wide angle colonoscopy. the development of endoscopy, we can see this right image as a high definition endoscopy more than high definition than the older endoscopy as like left image. And after 20 20 to 11 years, and wide angle endoscopy, endoscopy, in colonoscopy is developed, and some older colonoscopy can see 140 angles like this, but wide angle colonoscopy like this is 170 angles. Then we can see the more a wide area of the colon and can detect more adenomas in colonic region. And I will speak about flat region. How to detect colonic flat region is this. Take care of following findings: slight reddish mucosa and disappearance of vascular network, abnormal light reflection, thickness and irregular Nokian's fold, and disappearance of fine network, etc. In this image, where is the flat region? It is adenoma in the maybe a hepatic fracture, and it is slightly reddish and absence of vascular network, and spray pigments. We can see these polyps like this. The second, the flat region is seen in this area, and after spraying of pigment, this region is seen like this. The importance is it's similar to former promise on reddish area, and the abnormal reflection of light is useful for finding this. And most important is spraying a pigment like this, and we can see more this adermos rightly. And this rectum a flat region exists in this image, but it is difficult to see a white light observation. The spray pigment, this flat region exists in this area. Then, like this flat region, chromoendoscopy is most useful to see. This is taking home message, repeated training to quite importance of get to the allocated scale for intubation and detector anomalies. Increasing adenoma detection rate is the best way to prevent patients from colorectal cancer deaths. Thank you for attention.
Okay. Thank you, Dr. Nakahata. And okay, then we would like to invite the third speaker, Dr. Nao Fujimori. He will talk about bile duct stones. So, Dr. Fujimori, would you start the presentation?
Okay. Thank you, Chairman, for kind introduction. And my name is Nao Fujimori from Kyushu University. So I am now engaged in the endoscopic pancreobiliary endoscopy using the including the US and the RCP. So today's seminar is about endoscopic management of bile duct stones. Okay, this slide shows today's agenda. And firstly, I would like to talk about the management of acute cholangitis. And I would like to introduce a Tokyo guideline. And the second, endoscopic removal of bile duct stone, and especially for the difficult stones. Okay. So acute cholangitis, as you know, HC is a very important disease because bile duct stone, CBD stone, is a major cause of AC, and AC is a common disease in an emergency unit. And severe AC sometimes can be lethal. So therefore, recognizing appropriate and prompt management of AC is essential for all clinicians. So diagnosis of AC, as you know, the charcoal triad, including right upper quadrant pain, abdominal pain, fever, and jaundice, is a very simple and famous criteria for diagnosis of AC. And its specificity is very high. But on the other hand, sensitivity is low. So we need more accurate diagnostic criteria. From these conditions, Tokyo guideline is established as an international consensus guideline. So this table shows diagnosis criteria for AC proposed in the Tokyo guideline. And the diagnosis criteria consists of 3 pathologies. And one is systemic inflammation, and cholestasis, and imaging. And the systemic inflammation must be present. And in addition, if the patient has cholestasis, such as jaundice, or the biliary lesion by the imaging modalities, if these conditions, we strongly suspect acute cholangitis. And another important point is the severity of AC. So this is also shows severity criteria grading in Tokyo guideline. And grade C, very severe condition. Severe acute cholangitis is that AC with any one of organ dysfunction, such as cardiovascular dysfunction, or neurological, respiratory, or renal dysfunction. And grade 2, the moderate cholangitis, is AC with any 2 of the following, such as abnormality of the inflammatory response, and high fever, and higher age, and hyperbilirubinemia or hyperalbuminemia. And the grade 1, and mild cholangitis does not meet grade 3 or grade 2. This grading is very important because timing of biliary drainage should be determined according to this grading. And that is grade 1 is mild AC, It can be managed with, usually can be managed with antibiotics. But grade 2, moderate AC, required early drainage, usually within the 2 or 3 days. And grade 3, very severe condition. Severe AC is required urgent period drainage and with organ support. Okay, so again, timing of period drainage should be determined in this grading. So accurate diagnosis and grading of AC is very important for all clinicians. And the biliary drainage is now is first choice is endoscopic drainage, including ERCP, using ERCP technique, and that is transpapillary drainage. And when ERCP is difficult due to the various regions, and the second choice is percutaneous drainage, including PTBD or PTGBD. And nowadays, recently, the new drainage method using using endoscopy, that is EUSBD, EUS guided drainage, is emerged. So for these conditions, nowadays, surgical drainage and rarely performed in this condition for biliary drainage, I think. So this is a schema of ERCP. It's I think the first choice of biliary drainage. So we insert the duodenoscope to the major papilla, and to transpapillary biliary intervention will be performed. So I'd like to show the typical case of severe cholangitis. This case is, we experienced this case just 1 week ago. And 70 years old, he male, and he has previous history of IgG4 related cholangitis. And he had fatigue and appetite loss for several days, and disturbance of consciousness appeared. So he transferred to our emergency department. And his general condition is very bad, with high fever, with hypotension, and renal dysfunction, respiratory dysfunction. And he has abdominal tenderness. So laboratory data examination reveals a marked elevation of the inflammatory response. And in addition, the low blood rate and the liver dysfunction and renal dysfunction. So from these findings, we strongly suspect of severe acute cholangitis. So we performed the CT, and the CT detected the biliary dilation and the CVD stone. So definite diagnosis of severe acute cholangitis we can obtain. And he has also septic shock state with multiple organ dysfunction. So we planned the urgent biliary drainage with intensive care. And the patients directly go to from the emergency department to our endoscopic room, and we perform the ERCP. This is a papilla. The first biliary cannulation. After the cannulation, the continuous sputtering of fluent bile from the papilla. Many large amount of the bile you can see from the endoscopic view. This is a typical sign of the acute severe cholangitis. And we inserted the guide wire into the hepatic duct. The insert is a plastic stent with a nasobiliary drainage tube as an external drainage. Okay, you can see the inside the stent and the outside stent. So that case was a typical case, and we endoscopic drainage using ERCP technique. But it's nowadays the new drainage method using endoscopy is emerging, and the USBD is guided drainage. But today's lecture time is limited, so I would like to only introduce the concept of USBD using a video. Okay. So firstly, we inserted the echo endoscope into the stomach, and from the stomach, the punctures intrahepatic, left intrahepatic bile duct, and the guide wire insertion into the CVD. After that, and metallic stent for this case inserted. So So this technique using called the USHGS hepaticogastrostomy was completed. And this endoscopic and US guided method treatment is very rapidly developed. So in the future, maybe one of the attractive option for biliary drainage. So the second topic is endoscopic removal of bile duct stone, especially for treatment of difficult stones. So endoscopic removal of bile duct stone it consists of three procedures, such as biliary cannulation, ampullary intervention, and the stone extraction. So ampullary intervention includes ESD, endoscopic sphincterotomy, and EPBD, endoscopic papillary balloon dilation. This is a standard schema, a technique of ERCP. Firstly, biliary cannulation and the confirmation of the CBD stone by the injection of the contrast. And the next is ampullary intervention, EST or EPBD, balloon dilation. And finally, stone extraction is performed using the basket catheter or balloon catheter. And ERCP, as I said, is very useful and effective treatment for CBD stone. But all clinicians or endoscopists should recognize a severe complication or the possibility of severe complication, such as post-ERC pancreatitis PEP. The PEP occurs, left figure shows a PEP, and the right figure shows a WOM developed after PEP. Severe PEP occurs is about 0.1% of all patients, and the mortality rate of ERCP is 0.01%. So all clinicians should recognize that PEP is one of the most serious complications associated with endoscopic procedures. We have to be very careful. And let's back to the management of bile duct stone. So what is difficult stone? This is a flowchart is from the ESG guideline, the European Gastroenterological Society in 2019. In this chart is a difficult stone is defined as larger. The size is larger than 1.5 centimeter and multiple stone. And for these stones, difficult stones, guideline recommends EPLBD, means endoscopic papillary large balloon dilation. And like this figure, you can see the multiple and the large size CBD stones. For these patients, I recommend the EPLBD. So EPLBD means endoscopic papillary large balloon dilation. It's a procedure using a large balloon dilation, use large balloon to dilate the orifice of papilla, and with or without ESD. And the aim of the EPLBD is to improve the rate of complete stone removal in a single session and to shorten the procedure time. Okay, again, I would like to show the concept of EPLBD using a video. So firstly, I'd like to insert the duodenoscope to the major papilla. And you can see the multiple stones and cannulation and contrast injection. After that, ESD. In addition, the large balloon is used. And after the sufficient dilation of the bile duct, the complete stone removal very easily performed. This is a balloon catheter. Okay, it's a concept of EPLBD. I think it's very useful procedure, but the indication is EPLBD is shown in this slide. As you can see, in the left part, and sufficient dilation of distal bile duct is a good candidate of the EPLBD. On the other hand, the patients with biliary stenosis is a contraindication of this procedure because of high risk of the perforation or biliary injury. So I'd like to show the presentable case of large difficulties. That is the same schema as I presented in the previous slide. You can see the multiple large CBD stones. And this is a video for these patients. So I biliary cannulation and confirmed the multiple stones. And firstly, ESD was performed using a sphincterotomy. Okay, after them, EPLBD was performed using a large balloon. This is a fluoroscopic view. After the EPLBD, sufficient dilation of the orifice was achieved. So I used the balloon catheter to extract the stone. And finally, the large stone should be extracted using the mechanical lithotripsy to prevent the impaction of the stone. Okay, this is a figure after the EPLBD. As you can see, the multiple large stone is completely extracted. The procedure time is, in this case, I think it's only 30 minutes. So if the, of course, the indication is very important, but EPLBD, this procedure is very useful for these patients. Okay, finally, I'd like to introduce a recent randomized control trial, RCT, conducted in Japan, and regarding the EPLBD versus ESD. So in this study, see the patients with CBD stones larger than 10 millimeter, it's a large stone, were included, and randomized into the EPLBD without ESD or ESD alone. And as a result, and the single session complete stone removal rate was significantly higher in the EPLBD group without ESD group rather than the ESD group. And the adverse events, including PEP, is almost same in the both groups. So from this study, maybe I usually perform ESD prior EPLBD, but is maybe EPLBD without ESD is maybe one of option for large CBD stone, but it's a further larger studies required. Okay, this is my take-home message. And appropriate diagnosis and grading is essential for treatment of acute cholangitis. And most bile duct stones nowadays can be managed with ERCP, as I showed in the video. And in the difficult case, I recommend the EPLBD is recommended. So this procedure is an effective method for difficult stones. Okay, thank you again for giving me the opportunity to present my my endoscopic procedure. And this is I just 1 year ago. We went to Myanmar in your country and performed ERCP with many medical staffs. So I'd like to, I hope in the future, after the overcoming the COVID-19, I'd like to go your country again. Thank you for kind attention.
Okay, thank you, Dr. Fujimori.
Thank you. Thank you, Dr. Fujimori, for your very nice presentation about ERCP. Now it's a time for question and answer. The first question, so for Professor Moriyama, what medication do you use for mucus and foam removal for upper GI examination in Japan?
Okay, for the PrEP, the anti-foam agent and the mucolytic agent is essential. So then usually we add the simethicone and acetylcysteine will be included in the water, and we irrigate these agents and via the scope channel just before the observation.
Thank you. What do you think about COVID? During COVID time, do you usually use that simethicone and other agent in endoscopy procedure during COVID time?
Yes, we usually use because without removing the mucus and the forms, it's very difficult to detect the early cancer in the stomach.
Yes. Now, second question for colonoscopy. Do you usually use the flight assistant endoscopy to improve ATR for colonoscopy?
I think most useful device is a cap assist colonoscopy. And using a pigment is useful. And I mostly use the two things.
Right. So you usually use a cap in your day-to-day practice. So that question is, for detection of colorectal polyp, retroflexion is done in both right or left side of colon. Which part of the colon for reflection?
We must pay attention to risk of perforation, and it is difficult to use this retroflexion techniques in the right side of the colon. Sorry, left side of the colon, and it is useful this technique in mostly right side of the colon and rectum, in rectum.
Okay. So, and another question for ERCP. How long do you inflate the balloon for EPLBD?
The question is the time of the dilation time.
Yes.
Yes, usually 15 or 30 seconds. And if you can see the disappearance of notch, I think it's enough.
Yes. Okay. So did you usually do endoscopic sphincterotomy before dilatation? Routinely do endoscopic sphincterotomy?
Your question is regarding the EST prior EPLBD?
Yeah, yes. Before PD balloon dilatation, did you do EST?
Yeah. I usually perform the EST, but it's a recent study or recent publication tends to be about the without EST. Only EPLBD is enough. I don't have the conclusive comment,
Right.
but yeah. But it's for the patients with coagulopathy and some patients who has a drug, anticoagulants.
Mm-hmm.
It's a very tendency of bleeding. So I recommend only EPLBD without EST. And the surgical altered anatomy, sometimes very difficult for ERCP. So for EST, I also recommend only EPLBD.
Thank you. The next question for H. pylori. For patients with atrophic gastritis and intestinal metaplasia, how frequent should we do endoscopic screening?
Okay, thank you for good questions. Unfortunately, we don't have a definite answer to this question still. But in Japan, usually we recommend people with atrophic gastritis or intestinal metaplasia to undergo annual or biannual endoscopic exam.
Okay. I think this is the last question for our session. So after H. pylori eradication, rapid urea test is used to confirm eradication if endoscopy is indicated.
Okay, rapid urease is not good enough to check the status of H. pylori after eradication because its sensitivity and the specificity is not so high comparing to the urea breast test. So usually better to use the urea breast test to check the status after eradication.
Okay, so it's nearly 1 hour. So I really think.
Excuse me. I have a question.
Yes.
Because we still have time for 5 minutes. And actually, not a question. Maybe that is what we have to do in future. I mean, maybe you already have. Because I noticed that if you compare with Japan and Myanmar, incidents and then also, mortality quite, striking figure. That's why I would like to know the question actually to the Xiao, and then also maybe we would like to have advice from Japanese team and how we can reduce the mortality. Are there any national plan to reduce the mortality for the gastric cancer and colorectal cancer? Thank you. And then the Japanese team, you can give advice to us.
Thank you for your very good questions. To reduce mortality of gastric cancer and colon cancer, the early detection is an important issue. For that, we need to educate people, medical doctors for early detection of gastric cancer and colon cancer. And then we must force and advise to health authority, including minister for screening program for gastric cancer and colon cancer. So screening is quite important to detect early gastric cancer and early colon cancer. If we detect early gastric cancer in early stage, the mortality will definitely reduce.
Yeah, and that's why I was thinking, to have early detection, we need human resource for the early diagnosis, and then also facility and technology. Maybe three things.
Yep.
For that, human resource, I just like to ask to the Japanese team. Like Myanmar, we have 54 million, you have 125 million or something like that, 126. And in your country, how many people they can do diagnosis in the gastric cancer? I mean, doctors or how you organize and how you set up the US system.
Okay. All right. Regarding the human resources, it's very difficult. Actually, we have a long history to overcome gastric cancer. So education is most important, I think. So as I and Dr. Nagahata mentioned, there are so many tips for detecting flat lesion in GI tract. So to detect such kind of the subtle changes, the experience and the knowledge is needed. By teleconference like this, we can share the knowledge and the experience through teleconferences. So it is very important to join our teleconference or some other webinar from other countries or something. And also then AI, now AI is dramatically spreading to the world, especially in the endoscopic field. Some commercial company already launched the early detection system by AI. So this can be a game changer, actually. But then still, we should make a responsibility for the diagnosis by AI. So we should establish our knowledge through the education, I suppose. And another one is time limited.
Thank you very much. Because of the short, time, I mean, maybe we organize one meeting, or maybe we discuss on the online, or maybe discuss on the email for their topics. Thank you very much. Sia, please.
Yes. Now we have to conclude our session. So thank you very much, Professor Moriyama, for your very interesting lecture about gastric cancer. Thank you, Dr. Nagahara, for your interesting topic about colon cancer. And my thanks will also go to Dr. Fujimori for your very interesting presentation about ERCP and CBD stove. I also thanks the Kyushu Hospital and the rector of University of Medicine 1 and the supporting team, participants, and the GTEC and Professor Shimatsu for your kind support for today's symposium. I also thanks Myanmar Medical Association for allowing us to participate in your great conference. And thank you, everyone. I hope to see you again soon in person. Thank you very much. Arigatou gozaimasu.
Thank you.
Thank you, Mingalaba. Bye bye.